Good morning, everybody, and thank you, Bridge, for a great talk. This is a great segue into my presentation. So, Bridge has just spoken about, we were given this topic about fat but fit. Should we treat them or should we not treat them? So I have to be the devil's advocate and say, let's not treat them. It's okay to be fat, it's okay to be obese. Is there any data supporting this? And really speaking, just like we talk about in blood sugar, as to how low should we go, whether it's pregnancy, all these various situations you just saw, how low should we go when we are trying to treat our obese individuals? What is a safe cutoff? So this is perfect. Bridge ended with this slide, and I begin my talk with this slide. We are so well coordinated. So as we all have just seen, there are significant comorbidities associated with obesity. And to your left, I show you the ones that we worry about. Is this cardiometabolic syndrome, the risk of dying from CV disease, diabetes, cancer, and last but not the least, of course, obesity may lead to an increased mortality and premature mortality. So what I want to show you over here is there a pointer? Okay, I can use this arrow. As you can see, these are various BMI categories. So in the pink, you have 25, 30, 40, and 40 plus. So what's interesting is I've listed the chronic diseases, diabetes, chronic heart disease, and hypertension. What you will see is that as the BMI goes from 25 to 30, look across the board, the risk seems to be, it's there, it's not that high, but the minute you start getting into this blue zone, BMI 40, see how that risk jumps up. In the next slide, same thing. What does this translate into? For people with obesity, there is a decreased life expectancy. Again, the same thing. BMI 20 to 30, and here are years of life lost. You can see, again, when you start getting into the higher BMIs, that risk just seems to jump up a lot more. So what I pose to you is the question, so what is the missing link? Does it truly, Dr. Bray, who posted this question in an editorial not too long ago, if we lose weight, will we live longer? So what we do know is that the reason this question even comes up, because there has been this obesity conundrum, the obesity paradox, that intentional weight loss has been shown to increase, decrease, or really have no change in mortality following non-surgical voluntary weight loss. Same thing with CV disease. The data is skewed that yes, obesity leads to CV disease, but does losing weight cause decrease in mortality and decrease CV risk? And lastly, cancer. Similarly, even though we do know that there is an association of weight gain and cancer risk, multiple studies linked to voluntary weight loss have reported reduced cancer risk, and others have reported an increased cancer risk. So that's where I pose the question to you is, should we really be treating our BMI more than 30, the obesity or overweight? What should we be treating? Are we treating BMI as a number just like we are trying to move away from HbA1c? So should we really just be looking at BMI? Do we look at body fat? Do we look at metabolic syndrome? My colleague has described to you what is MHO. And finally, what is the role of fitness in all of this? Where does it fit into the picture? And what is this implication on all of us when we treat our patients as clinicians? So as you're well aware, the NIH uses BMI to define obesity, and so do several of the different bodies. What we also know is that BMI may not always correlate in our South Asian population with body fat. Similar, if you look at, this is the YY paradox that you're all aware with, so I will not spend too much time on this. And lastly, the three things that we want to look at is the metabolic syndrome, as was looked at in all of these patients, looking at abdominal obesity, triglycerides, HDL cholesterol, blood pressure, and a fasting blood sugar. So the obese healthy, as Bridge has well defined, I don't need to spend too much time on this, is a subset of patients who are a BMI more than 30. If you're going to call them metabolically overweight and unhealthy or unhealthy, it's going to be a BMI more than 25. And then we look at the various parameters as described by the metabolic syndrome, and they need to have at least more than one or two to be called as MHO. So in the NHANES database, I'm just going to show you what is the prevalence of this MHO in various populations. In the NHANES database, they did the same similar study. They looked at 6 parameters for metabolic disease. They actually also looked at insulin resistance. And what they found is for metabolically healthy, they used 1 or less than 1 abnormality. Unhealthy was 2 or more abnormalities. About 5,500 patients were studied. They were excluded if they had known CV disease. And lo and behold, if your BMI was more than 30, the prevalence in this particular database was about 32%. 71% were Caucasians, 12% African American, and 20% other groups. Let's look at the risk in Chinese. You know what always comes to our mind is the Chinese who look so lean, just like us, like us, Southeast Asian Indians. In a 2009 China Health and Nutrition Survey, similarly 8,200 patients, and the prevalence in this database, 20%. So a little bit lower than the Caucasian data. Now, what about the Asian Indians? So this study conducted in about 2,300 Asians, so it's a smaller group, BMI more than or equal to 25. And what do we find? It seems to be much lower. So for some reason, even though our BMI is lower, 13 to 15% only were healthy. So we fit into the overweight or obese category, but we have a higher number, but we still have this 15% of population we need to address. So the question that I bring back to your mind is that, should we really treat them? What should we treat? So let's look at the data. So this is a nice meta-analysis which looked at, as I showed you in the beginning, why do we worry about this class? Chronic diseases, CV mortality, cancer are the three things that topmost come to mind. So the aim was to examine, will we die? Do you die if you lose weight? So this is not looking at MHO, it's looking at the effect of weight loss on all-cause mortality. They looked at about 26 studies, and they followed them about 15 years out, following weight loss only by a lifestyle change, non-surgical intervention. They then divided the groups into metabolically healthy. So bear with me on this slide. If you can read, the top 8 or 9 studies are metabolically healthy. At the bottom, we have the unhealthy group. As you can see, the mortality risk for intentional weight loss, according to health status, did not seem to be affected much. It was actually better in the metabolically healthy group if they were compared to metabolically unhealthy group. Okay? Now, here's the enhanced database. They looked at all-cause mortality risk of MHO individuals in Enhanced 3. What did they do? They actually conducted the HOMA insulin resistance, they looked at the ATP criteria, and then they also combined, and about 4,000 patients were studied. So here you can look at the HOMA insulin resistance. Again, the blue is healthy and the red is unhealthy, obese, overweight, and lean. Across the board, if you were metabolically unhealthy, you can see there's a higher risk of dying, except in the overweight group, it was about similar. And same thing with the ATP3 criteria, you can see that the metabolically healthy obese participants were not very different from the healthy lean individuals. So it did not seem to increase their chance of dying if they were metabolically healthy. So what they also saw is that they followed these individuals out, and they found that the ones who had a lesser chance in the subgroup analysis, they were younger patients, or they were followed up for less than 10 years in some of these studies. So maybe after 10 years, the MHO will convert to something else, to convert to unhealthy. And the ideal weight for longevity in this class was the overweight category, the BMI 23 to 30. So again, this behooves us to think, should we treat BMI or should we look at something else? What is it that protects the MHO subgroup in the beginning from CVD risk or from the risk of dying? So now, again, we look at another meta-analysis to try and answer these questions. So similarly, here are 8 studies, huge number of patients, 61,000, and longer follow-up. That's where I was trying to get to. Maybe if we follow them out longer, they'll start converting into unhealthy. Maybe they will start having CVD risk or mortality. So again, this group was classified as MHNW is metabolic health, normal weight, metabolically unhealthy, normal weight, overweight, obese, and then so you can start seeing that they get into the metabolically unhealthy group. This is our group of interest. You can see the overweight and the obese. At the end of more than 10 years, their risk versus the normal weight or metabolically healthy, the control group, was 24% higher. So if you follow them up out 10 years, what I really want the audience to look at is look at this second group, the second row, normal weight individuals, but metabolically unhealthy. And what's the risk, relative risk you see? 3.14 versus controls. So even with a normal weight, if you're metabolically unhealthy, it gives you a much higher chance early on of developing CV disease as well as mortality. And therefore, the authors conclude over here that the metabolically unhealthy certainly had a high rate compared to the metabolically healthy normal weight, but attention needs to be given to the metabolic status much more than weight, because even in the normal weight individuals, I've shown that these patients are high risk. And the rate of conversion, if you follow these subjects more than 10 years, seems to be 34% and 50% at the end of 15 to 30 years. So in synthesis, what I now pose to you is that the primary soil is not the weight. The primary risk factor is the metabolic status. obesity seems to be then the secondary or the driving force. Sorry, the slide keeps moving. Yeah. So therefore, we need to now, instead of thinking, let's classify them by BMI, should we change the way we think and classify them first based on metabolic staging, and then as a secondary risk factor, classify them by BMI, and then try to work on our patients, because obesity seems truly to be the enabling risk factor. Okay, so we try now to move on and say, so now what are we trying to treat? If they're metabolically healthy, why are they healthy? So what is the confounding bias in most of these studies, what I'm unable to present in 20 minutes, is we have not looked at the several things, such as the ethnicity, the genetic background, family history, the macronutrient compositions of their diet, the kind of fat cells. So there are certain studies, some of the studies had some smaller data looking at this metabolic health in the obese phenotype. But what would be of interest is if we can identify why they fail to develop CV risk. For example, I have several patients in my clinic who are 70 years, close to 70 years, in the age group of 60 to 70 years, and their HbA1c has hovered in the range of 5.7 to 6% for several years without converting. They have continued to put on weight, they continue to live their life, eat whatever they want, and somehow they never seem to tip the balance and go into the diabetic range. So why does that happen? That is what I'm trying to put in a more clinical scenario. So now moving on as to, do we need to look at the fat percentage? Do we need to look at fitness? Is there something to do with fitness that protects these individuals? In this particular database, we have 43,000 adults, and they looked at body fat percentage. They first classified them by BMI, and they started looking at body fat, and what they found that there was an even higher number of people when you looked at body fat percentage who would fall into the obese by body fat percentage criteria. More than or equal to 25% or 30%, and men or women respectively were looked at. And then they assessed the fitness in these individuals with a treadmill test, and the body fat was done by hydrostatic weighing or skin folds depending on the study looked at. Okay, so now what they did is then they classified these individuals. If you look across the top, there's BMI-based obesity, body fat percent-based obesity, and then they also classified them into metabolically abnormal or healthy and metabolically healthy normal weight individuals. What they found is, and then they did a fitness adjustment for the hazard ratio. This is the unadjusted hazard ratio, and then adjusting for the fitness levels. When they adjusted for fitness and other confounders, they found that the MHO subgroup had a lower risk, 30 to 50%, of all-cause mortality, non-fatal, and fatal CV disease. They also put in a cancer mortality because they followed these patients up to 20 years. So now I also show you cancer data that MHO did well if they were fit compared to their unhealthy and obese peers. And no significant differences were seen between MHO if they were fit and with the normal weight control groups who are metabolically healthy. So now I post you the third player in this group is I told you initially that let's classify them by metabolic risk. Obesity is a driving factor, but what you can see over here, the cardiorespiratory fitness, the green arrows, if you look at the legend to your bottom left, decreases the risk, and the red arrow increases the risk. So CRF, as Dr. Makar has shown, the high sensitivity CRP being high in the obese group, it would be really nice to look at also their fitness levels and see how it correlates in your particular study base to their fitness levels. Because we know fitness will reduce your inflammation, endothelial dysfunction, all-cause mortality, and also it seems to reduce all the other metabolic risk parameters. And is this the reason why the MHO group was healthier? So what the authors in this particular study concluded that higher fitness was certainly seen in this MHO subtype. Once fitness is accounted for, there was no difference in these individuals and the normal weight individuals. So what can I tell my patient who is not converting? Why should they stop eating? In Gujarat, they love their fafda jalebi. Why should they stop eating? We should have a reason to do it. Or how can they continue to eat and have a semblance of a normal healthy diet and still follow a lifestyle pattern? So what should we use? Now I'm going to change my angle and be really, try to show you where the world is going. So the Welsh Health Survey shows just recently that 58% were classified as overweight and 22% as obese. So the majority of the Welsh population, this tells you about 70%, are they obese or overweight? So we have to also pick, do we want to be in the minority group or do we want to be in the majority? The world is becoming obese. The US database is showing you, as you can see, the trends that almost, if you look to the left, is a percentage. 40 to 50% of US adults are overweight or obese, and I do not show the pediatric data, but it's about half of this already, 25 to 30%. Okay. Now here's what we have so far. Even our treatment guidelines, although they are based on BMI, I was happy to look at them in a new angle. They tell you that you have to look at BMI and comorbid conditions. In fact, even they say that start with diet, physical activity, and behavior therapy when your BMI is 25, but with comorbidities. And only you use pharmacotherapy. So when you talk about treating, how are you trying to treat and what are you trying to treat? So certainly no one is saying do not, a diet even for a lean BMI in the Indian context may not be something that you want to move away from. So therefore, I propose to you, this is the Edmonton clinical staging system for obesity, which puts things in a new perspective. Because we really need to put on our different glasses, and get away from just thinking, let's treat weight as a number, let's treat obesity, and look at the clinical staging. So Edmonton, what they proposed from the Canadian group, from Dr. Sharma and Kushner's publication, that we really should stage obesity more based on the underlying medical, mental, and functional complications. And then we can say if there are no risk factors absent, maybe we don't need to be aggressive with them. Preclinical risk factors, stage 2, stage 3, and stage 4. So a different view for looking at this. Similarly, the ACE algorithm for metabolic syndrome, it says lifestyle modification, including medically assisted weight loss. And what I like nicely, they divided into the CVD risk factors, anti-obesity therapies, and also when you start, when normal glycemia is lost, you move into anti-hyperglycemic therapies. Okay, so putting all this together, I have just taken you from a common soil hypothesis to now looking at it differently, that MHO individuals, the metabolically healthy obese individuals, the reason we might see this is that they are younger or we have less than follow-up, less than 10 years in some of these studies. The ideal weight for longevity was the overweight category, so BMI 23 to 30. So when we are treating these individuals, let's not focus our attention on weight, but let's work more on the metabolic parameters. Let's work on body fat as a target and use our macronutrient composition accordingly. In fact, what we fail to look at, if a person looks lean, these are the people we ignore because we are not currently staging them by metabolic status. We need to really look at if there's a family history, if there is anything suggesting in this patient's family history or personal medical history, we need to do a metabolic staging for this individual because they are much higher risk, as I've shown you, than the other individuals despite a normal weight. Fitness, so we really need to work on fitness, and once fitness is accounted for, as I showed you, the MHO subtype seems to be as healthy as your normal weight individuals. And last but not the least, of course, more insights into mechanisms are needed. Just to end on a couple of weeks ago, we started getting this WhatsApp messages. Cholesterol does not cause heart disease from when the ATP guidelines came out, the ACP, and I got so many WhatsApp forwards of this particular photograph with the background data. Then you get sometimes pictures your patients send you, should I go on a ketogenic diet, should I, eating fat is not the enemy. So really, we should be thinking about what we are trying to treat, and we need to give a very balanced, logical answer to our patients. Thank you very much for your attention.